All right.
Good morning. Oh, I'll go ahead and present you.
Oh, go ahead. No, you.
No worries. Good morning, everyone. Thank you for coming to our presentation today. Today's presenter is Dr. Colleen Maturana, presenting glaucoma Awareness Month Facts, Diagnosis, and Treatment. She's a board certified ophthalmologist and assistant professor of ophthalmology at Weill Cornell Medicine. She specializes in the medical and surgical treatment of glaucoma. Dr. Maturana grew up in New Jersey and went on to obtain her undergraduate degree from Columbia University with a major in biology. She attended New York University School of Medicine before completing her residency training at Mount Sinai Hospital, where she was a chief resident in her final year. After residency, Dr. Maturana continued her training at Cornell with specialization in glaucoma. She is trained in both the surgical and medical management of glaucoma, including not only traditional filtering surgery, but also an array of minimally invasive glaucoma surgeries. She is dedicated to staying up to date in her field, especially when it comes to novel treatments, and prides herself on being able to offer most innovative therapies to her patients. We will be recording this session, and if you have any further questions, you can email us at ctsc/community@med.cornell.edu, and I will be posting in the chat and the description on our YouTube channel. The next voice you will hear is Dr. Maturana. Thank you.
Thank you so much. Thanks for coming, everyone. So yeah, I'll go into glaucoma today, and then at the end of the presentation, I'm happy to answer any questions that you guys have about ophthalmology in general. So before we start talking about glaucoma, I think it's important to just have a basic understanding of eye anatomy and how the eye works. So here, this is a cross section of the eye. The eye is a very complex organ. It has many different parts. I'm just going to talk about some of the important ones for glaucoma. So when you look at someone's eyes, usually you're focused on the colored part of their eye. And that colored part is called the iris. And it's actually located behind a clear layer called the cornea. I like to think of the cornea as the windshield and the iris as the driver of a vehicle. So if you're looking through the windshield of a car, you can clearly see the driver, but it's through that windshield. The black circle that you see in the center of the iris is called the pupil, and that's actually a hole to get to the back of the eye. So in the figure at the top of the screen, you can see that light passes through the cornea and the pupil. Look at the eye. And that's where the optic nerve is located. The optic nerve is a combination of all the small nerve fibers that cover the retina, which is that orange layer in the back of the eye. When light hits the retina, that signal is transmitted through the optic nerve to the brain, and then the brain interprets that signal and forms the image that we see. The optic nerve is the most important part of the eye when we talk about glaucoma. From the cross section here, you can see that the eye appears hollow inside, and that space is actually filled with a fluid, like a water balloon. That fluid is constantly being made, and as you can imagine, if the fluid has no way of leaving the eye, the pressure can build up inside. So that fluid actually drains through an angle that's formed by the iris and the cornea, those two parts that we just talked about. And this making of the fluid and the draining of the fluid is really the basis for what we talk about in glaucoma. So before we get too in depth with the pathophysiology, let's just review some key facts about glaucoma. Glaucoma is a general term for a disease that causes damage to the optic nerve. There are many different types, and we categorize them into two main groups: open angle and closed angle. And the angle that we're referring to there is that angle we just spoke about between the iris and the cornea, and that's where the drain is located. Glaucoma is the second leading cause of blindness worldwide after cataracts. Almost 1 in 10 people over the age of 70 have an elevated eye pressure, and about 4 million people in the United States have glaucoma. Unfortunately, the damage that's caused by glaucoma is irreversible. So the optic nerve is very much like heart tissue or brain tissue, where once you have damage to that tissue, the body cannot regenerate it, and that damage is irreversible. There are, like I said, different types of glaucoma, many different types. But in general, we categorize them based on that angle, based on that drain, whether the drain is open, which is open angle glaucoma. That's the most common glaucoma that we see. Or if it's closed, then we call it closed angle glaucoma. There are many risk factors for glaucoma. Some of them are history of eye surgery or trauma, family members who have glaucoma, being of Black or Hispanic race, and advanced age. So today we'll focus mostly on open angle glaucoma because that's the most common type of glaucoma. And this type of glaucoma is often associated with high pressures, but it actually doesn't have to be. When we talk about eye pressure, this actually has nothing to do with your blood pressure, and it can only be measured when you have an eye exam. You can't know what your eye pressure is without actually having it measured by an ophthalmologist or an optometrist. Like I said before, the damage from glaucoma is irreversible, and unfortunately, it's actually asymptomatic until it's very advanced. People who come in who have mild or moderate glaucoma have no symptoms at all. They would never know that they have glaucoma. It's usually people who have very advanced glaucoma who come in with a complaint of decreased vision. The treatment of glaucoma is aimed towards slowing down and hopefully preventing any further damage, because like I said before, once that damage has occurred, we can't do anything to bring it back. So in general, glaucoma affects the peripheral vision, although it does sometimes affect the central vision as well. And it continues to worsen over time. And so people who have very advanced glaucoma will have both peripheral field defects and central field defects. In this photo here, you can see what the effect of glaucoma could be on what you see. So that central vision is very clear, whereas the peripheral vision is not. And this is different from macular degeneration, where actually it's the opposite. People who have macular degeneration have peripheral vision that's spared, but it's really their central vision that's affected. So how do we diagnose glaucoma? Every time you have an eye exam with any eye doctor, really an ophthalmologist or an optometrist, you'll have your eye pressure checked and they'll look at your optic nerve. There are different ways to check the eye pressure. I'm sure everybody's experienced that air puff before. The most accurate way, though, is through what's called applanation, which is depicted in the photo on the left here. This is when we lightly touch the cornea with an instrument and a blue light. And it's not painful because first you have anesthetic drops, but a normal pressure is below 21. If your pressure is higher than 21, then that is suspicious for glaucoma. At your visit, the doctor's also going to look at your optic nerve to see whether it appears suspicious for glaucoma. If there is a concern that you may have glaucoma, there are really 3 tests that we perform in order to diagnose and then follow any possible damage that's been caused to your vision. These tests are the visual field test, the optical coherence tomography, or OCT for short, and color photos. The visual field test is basically a map of your peripheral vision. It takes about 15 minutes to complete. You sit at a machine where you'll look straight ahead, focused on central lights, and then in your peripheral vision, you'll be shown very bright but fast lights, and your job is to click the button when you think you see those lights. The machine then can map your peripheral vision, and where you were shown a light but didn't click the button, that will come up as a gray or black area on the map. So you can see here, this is an example of one of those visual field maps, and this person inferiorly in their field of vision has an arcuate defect from glaucoma. The second study that we'll do when we're diagnosing glaucoma is the optical coherence tomography, or OCT. The OCT is really just a picture of your optic nerve. It measures the cross-sectional thickness of the nerve tissue, and it actually compares your nerve tissue to an age matched population that does not have glaucoma. In glaucoma, what we find is that the optic nerve can become more thin over time as there's damage to that tissue, because you're actually losing nerve tissue. In this study, the green means that there's no thinning and you're within, the average for your age. Yellow or red means that the tissue is thinner than it should be, than we expect it to be. And this test is great because it allows us to have an objective way to measure the tissue loss over time and to look for progression of your glaucoma. Oftentimes, actually, people can have changes on this test before they have changes on the visual field test. So before you actually have any effect to your functional vision, we can detect glaucoma very early on with this test. And then finally, the third test that we'll do is a color photo of the optic nerve, because there are many changes that can occur to the optic nerve structure itself in glaucoma, and we like to be able to track that over time. Here you'll see a picture on the left of a normal optic nerve. The blood vessels are coming out of the center of the nerve, and then there's that orange tissue in a ring, and that's healthy optic nerve tissue. On the picture in the right, you can see that the center of that nerve is a much brighter yellow. It's not that healthy orange color. And that's because this person has actually lost a lot of their nerve tissue from glaucoma. And this is very helpful for us, especially over time, to see any subtle change in the optic nerve that we may be missing by our exam alone. The only way that we know how to treat glaucoma is by lowering the eye pressure. That is our main goal. So how do we do that? There are really 3 different ways that we can lower the pressure in the eye, and they're aimed at increasing the fluid getting out of the eye or decreasing the amount of fluid that the eye is making. We can use laser treatments in the office. We can start eye drops, or if needed, we can do surgery. The treatment for glaucoma is lifelong. So once someone has been told that they have glaucoma, like I said before, the treatment is really to slow down the progression of glaucoma. There's no way that we can get rid of the glaucoma or cure it completely. So let's talk about the laser treatment first. I actually encourage my patients to do this laser as the first line treatment. It works about as well as one eye drop in lowering the pressure, and works in about 80% of people that have it done. It lasts up to 2 years and it's repeatable. But unfortunately, every time we repeat this laser procedure, the effect is less and less. So usually after the 2nd or 3rd treatment, we would have to move on to something else to lower the pressure. It's very safe. It's done in the office. It's painless. After the laser, you may have a little bit of blurry vision, a little bit of light sensitivity, but overall, my patients really don't complain about that. And it's a good alternative to having to start an eye drop every day, a couple of times a day. So we have 6 different drugs that we can start for glaucoma. The dosing ranges in frequency from 1 time a day to 3 times a day. But even remembering to use an eye drop once a day is difficult. And unfortunately, these drops are very often associated with redness, irritation. Most people, especially in the New York City area, are suffering from dry eye, and these drops will definitely exacerbate that dryness. Some of the drops even have systemic side effects, such as difficulty breathing, low blood pressure, and it's common for people to actually develop allergies to these drops. So although this is really our best treatment right now for glaucoma, it's not ideal in any way. Luckily, over the last 10 years, there's been a lot of development in minimally invasive surgeries for glaucoma. In general, surgery is our last choice for the treatment of glaucoma. But these new minimally invasive surgeries are exciting because they can be performed quickly, safely. They have a better side effect profile, and they're oftentimes done at the time of cataract surgery. Most of them involve tubes or shunts that allow an increase in the outflow of fluid from the eye. Traditional, more invasive surgery is really done when somebody is still having progression of their glaucoma despite every other treatment that we've offered them. So some common questions that I get in the office, I'll just go over here. People ask me a lot whether there's something like an eye transplant that can be done for the treatment of glaucoma. Unfortunately, we can't transplant entire eyes, and because it's the optic nerve that's being damaged in glaucoma, I think we're very far away from having that ability. But we are able to replace the cornea in patients. So you may hear people who have had an eye transplant, and really what they're talking about is the cornea, that clear front part of the eye. It's also very common for people to confuse cataracts with glaucoma. Cataracts are actually a normal part of aging. They're just a clouding of the lens that you were born with. And this happens to everybody. It happens to different degrees, just like some people get wrinkles earlier on in life and some people tend to hardly have any. And it's easily cured with surgery. My patients also ask a lot about, how long am I going to need treatment for glaucoma? And like I said before, this is something that you'll have forever. It's a disease that we can't cure. And so the treatment will be lifelong. And then, marijuana, a lot of studies have been done looking at the effects of marijuana and eye pressure. And while it does have a transient intraocular pressure lowering effect, it's not sustained. And so there's no role for marijuana in treating glaucoma. So what can you do to prevent damage to your vision from glaucoma? Really, the best thing is just to see an eye doctor regularly, to go in every year or two to be screened. Like I said, we'll always be checking your eye pressure. We'll always be looking at the health of the optic nerve. And if glaucoma is found early, it's very unlikely to cause blindness, which is great. So make sure that you and your family know how important it is to go see an eye doctor for regular screening. Before I get to questions, I just want to talk about our Crest Vision program really quickly. So it's difficult for people to access medical care, especially eye care. And so at Cornell, we have this great program, the Crest Vision program, which is available to assist people who don't have insurance. And actually it includes vision screening, follow-up visits, surgeries, eyeglasses, medications if you need them. And to qualify, you can't have any medical insurance. You must be a New York State resident. You must meet the household income of at or below 200% the federal poverty line, and then submit an application. So I can have Agnes email that information out in case you guys want to spread it around. But I'm happy to answer any questions that you guys have.
Okay. Hello, this is Phyllis Herbert, and thank you for this presentation. It's very, very informative. My question is, I have a swelling under my right eye, which is not caused from sleeping because it remains there. I sleep very well. What do you think is the cause for that swelling that does not go away?
So in our orbit surrounding our eye is a lot of fat tissue to give our eye padding. And as we age, the tissues that hold that fat back actually weaken over time. So it's very common for that fat to kind of prolapse forward and cause like a swelling underneath the eyes.
But can that be removed?
So oculoplastic surgeons can help with that, but because we do need that fat to cushion the eye, a lot of times there's not too much that can be done about it.
Thank you. Thank you.
I was trying to speak before, but I didn't realize I was on mute. But if anybody wants to write in the chat also, I can speak out your questions if you're shy. And I'm also going to administer a poll while we continue the questions.
Hi, am I able to ask a question?
Yeah, everybody can speak out, yes.
Okay. My name is Phyllis Walker. I recently had a eye exam to get glasses, and in my left eye, it was like really cloudy. Or it had like these little, like white, I don't know, clouds or something in the pictures. And I was given a referral to go and see a doctor, but they couldn't tell me like anything about what it was. Does it sound like it's any one of the two things that you spoke about?
You know, it's hard for me to say just from that. If it was just a glasses check, then they probably didn't do a full eye exam for you, and you would really need a full eye exam to be able to tell anything.
Okay.
Yeah, sorry.
It's okay. I did schedule an appointment to go in. Thank you.
Okay, good. Good luck.
Thanks.
Yes, I have a question. My name is Josefa Perez. I would like to know what causes, because sometimes I see like little spiders like in the ear. What is that? What can cause that?
So the eye is hollow, like we saw in that cross section, and the back is filled with a fluid, with a jelly. And as we get older, that jelly collapses on itself and can cause those floaters. So you're actually just seeing a shadow of those floaters on your retina. In general, most people have those. Over time, they get better.
Happens to me too.
Okay.
Yeah.
Like-
We worry about them only if you have a lot of floaters, like having a snow flurry all of a sudden in front of your face. If you have a big change in the floaters, or if at the same time you're having flashing lights or blurry vision, then it could be a sign that you could have a problem with the retina, like a retinal tear or a hole or a detachment. So if you ever have a change in them, then I'd recommend that you go make an appointment to see an eye doctor for a dilated exam.
Okay. Thank you.
You're welcome.
There's a question in the chat also on the general cost of cataract surgery.
Cataract surgery is covered by insurance. It's covered by Medicare. The cost comes in when you start talking about extra things like using the femtosecond laser at the same time, which studies have shown actually doesn't provide any benefit, although some doctors feel that they perform a better cataract surgery with that laser, so they'll offer it to you. There are also what are called premium lenses. So at the time of cataract surgery, we remove that lens that you were born with, and we have to replace it with an implant, a clear plastic lens. And there are lenses that are covered by insurance that are great, and that's mostly what I use when I do cataract surgery. But some people are very, very motivated to be glasses free after cataract surgery. And in that case, we can offer what's called a premium lens, where you can have distance vision as well as near vision. And those lenses can cost $2,500 or $3,000 per lens, so per eye.
Wow.
Yeah, very expensive.
Yeah. Okay. Oh, and there was another chat that someone came late and they asked if there was like a population more prevalent to glaucoma, or if there was diseases, like underlying diseases that will lead to glaucoma quicker.
Yeah. So because there are so many different kinds of glaucoma, there are some situations where underlying diseases could put you more at risk. So like people who have very severe diabetes and have diabetic retinopathy are at risk for glaucoma. And then in general, people who are older, who are Black or Hispanic, who have had eye surgeries in the past, they're all at a higher risk for glaucoma as well.
Okay. And then there's another question on what causes tearing of your eyes?
The tearing.
Tearing, yes.
So tearing most of the time is actually caused by dryness of the eyes. So when the eyes sense that they're dry, they actually send out a signal for you to release a lot of tears all at once. And the tears that are released aren't the same as the healthy baseline tear that your eye should be producing all the time. So it doesn't tend to actually help the dryness very much. It just is very annoying. And so when someone comes in and they're having tearing frequently, what I'll recommend is starting with an artificial tear, actually, just over the counter from the pharmacy to treat the dry eye. And usually that will help a lot.
Thank you. Let me see if I missed any additional questions. Oh, Larry has his hand up. You can go ahead and talk, Larry.
Sorry, about those drops, is it such a thing as overuse? Is it one of those things where the more you use it, the more you need it? Or is it just basically water and don't worry about it?
Yeah,
like-
so that's a great question. So it's not that the more you use it, the drier the eye will be, but there's really two main types of artificial tears, ones that are in preservative and ones that are preservative free. And so when you buy them over the counter, if they're coming in a big bottle, that means that they have preservative in them to keep them, you know, from growing bacteria over the time that you're using it. Those I never recommend using more than 6 times a day, because the preservative is actually irritating to the surface of the eye. So if you end up needing to use the artificial tears more than 6 times a day, you should switch to the preservative-free formulation. But using the artificial tears is not going to cause you to become dependent on them.
Like nasal spray.
Right.
Once you
Yeah,
start, you
so
can't stop.
yeah, nasal spray. So those are different because they actually constrict the blood vessels. And so when you're talking about something like Visine for red eye, that you actually can become somewhat dependent on, because when you're using a vasoconstrictor, whether it's a nasal spray or an eye drop, the blood vessels become used to having that vasoconstrictor. And so once you stop using it, the blood vessels will dilate even more than they were before. And so your nasal congestion might even be worse than before you started, and the redness of the eye might even be worse. So for those types of things, you really shouldn't use them for more than 3 days.
Mhm.
When I wore contact lenses, I also use saline solution. Can you just use that for the drops? Or not a good idea?
Saline solution isn't as lubricating as the artificial tears. But with contact lenses, you have to be careful about using an eye drop that has a preservative, because the contact lens is really like a sponge. And so it will soak up that preservative and hold it on the surface of your eye throughout the day, and that will cause irritation. So people who wear contact lenses have to use an artificial tear that's specifically made for contacts, or a preservative-free artificial tear.
Got it. Thanks.
You're welcome.
Hi, I actually just have a question about, is there any reason, or maybe it's not known yet, why pressure builds up in the eye, or are there any causes for that?
So for primary open angle glaucoma, we really don't know what the cause is. For other types, we know like there could be something blocking the drain. There could be just an innate problem with the drain. But for the most common type of glaucoma, primary open angle glaucoma, it appears that some people are just more sensitive to the pressure inside of their eye. And like I said before, it doesn't even have to be a high pressure. Some people, actually, I would say a fair amount of my patients have never had a high eye pressure measured, and they still have glaucoma. And so it's a frustrating part of glaucoma to not know what the disease actually is, but
Yeah.
hopefully they'll figure it out at some point.
And is it usually glaucoma appears as you get older as well, right? Okay.
Yeah, usually that's the case. There are some types of glaucoma that are more prevalent in younger people, and those are really devastating because young people tend to not go to the doctor. They especially don't go to the eye doctor if they don't need glasses. And so those patients are usually the ones who are coming in with more advanced damage.
Thank
So
you.
it's important for everybody to see an eye
Yeah.
doctor. Yeah.
Yes, thank you.
Mhm.
I do have a question. Good
Okay.
morning. I'm sorry, really quickly. What would you recommend, since you did mention younger, right? What would you recommend to to people like myself? I do have some of my participants here also joining, that because of COVID, we tend to work more on the virtual side. Even though that we're working in person, we are more in the computer than usual. And then we also do school. So all those hours being on the screen, would that affect you as you get older? Or would it get you closer to even, being a risk of getting glaucoma?
Yeah, that's a great question. So using the screens does not harm your eyes at all, and it doesn't increase the risk for any type of eye disease, including glaucoma. What it does do is exacerbate dryness and eye strain. So I have a lot of people coming in who are complaining that their vision is blurry after they've been on the computer for a bit, or the eyes are tearing, or they get headaches. What I always recommend is something called the 20-20-20 rule. So every 20 minutes for about 20 seconds, you look 20 feet away, and that allows the muscle inside of your eye that's allowing you to see up close to relax. And then during that time, you can also take a moment to blink a bunch of times, because whenever you're focused on a task, especially when it's with a screen, you tend to blink less, and that will dry the eyes out more.
Thank you so much. I'm definitely gonna do that, because I do tend to have a lot of headaches and my eyes do drain a lot. And then when I go to the doctor, they're like, hey, you may need bifocals. And it's because of so much lighting through the computer.
Yeah.
Thank you, appreciate it.
You're welcome.
I'm gonna try that tip out too. Larry, did you have your hand up again for
Yeah,
another question?
maybe covered in those wool gathering, but I always thought of glaucoma by definition as an increase in intraophthalmic pressure. You're talking about glaucoma without pressure. So let's back up a moment. What is the definition of glaucoma, please?
Glaucoma is an optic neuropathy. So it's just damage to the optic nerve, and it's in a particular area of the vision in general. But there are so many different types of glaucoma, and like you're saying, most of them are associated with a high pressure, but they don't have to be. A lot of people have what's called normal tension glaucoma, where they've never had an elevated eye pressure and yet they have glaucoma.
So it's glaucoma because it's neuropathy at the optic cup,
Yeah, it's an optic neuropathy. It's just damage
but at the cup itself.
to the, yeah, exactly.
Okay. Because neuropathy can be anywhere, multiple sclerosis, you get a lot of that sort of thing. Okay, thank you.
Okay. If anybody else wants to chime in. Oh, yeah. How can a person prevent dry eyes?
I mean, there are things that you can do to help treat dryness, but if you have dry eye, again, it's a disease of the eye. And so there's really nothing that you can do to prevent it. You either have it or you don't.
Okay. And do carrots really help eyes in any way?
No. Having a healthy lifestyle and eating a healthy diet, taking a multivitamin, those are all things that I recommend. And I know that, you know, we all see the marketing for AREDS. That's actually a vitamin that's meant for people who have macular degeneration. There's no vitamin that's specific just for eye health in general. And
That thing's actually World War II propaganda.
yeah.
There's intentional propaganda against the Nazis. Why it is we be seeing their planes to hide the radar.
And could you just define macular degeneration?
Sure. Macular degeneration is a disease where you get a buildup of a proteinaceous material underneath the retina. And that material in and of itself doesn't cause a problem. The problem comes when the retina either starts to degenerate over those areas, or you have blood vessels that are abnormal that start to grow. And those can cause leaking into the retina. They can cause bleeding into the retina. And so macular degeneration, like I said before, it affects the central vision. So it can be really devastating. But our retina specialists actually can help to treat those more advanced stages of macular degeneration with an injection of a medication directly into the eye.
Okay, thank you. Okay, I don't see any more questions. Every time I tried saying that, then one more question came in, but I don't see any more questions now. So thank you so much for this informative talk. We look forward to seeing you again on speaking about eyes and all the other eye diseases out there and getting all the information that we possibly can get.
Yeah, you're welcome. Thanks for having me.
Thank you.
Doctor, I sent you a DM. I'd love to contact you privately. Is that okay?
Oh, yeah, sure.
Thank you so very much.
You're welcome.
Thank you.
Okay, bye.
Bye-bye.
Thank you. Thank you.
Have a blessed day.
Thank you.